to get involved when there's a disease or a reason to autopsy in a long-term care facility, for instance. But is there reduced autopsies when they're consented to by family? I would say no. Generally, in geriatrics, the cause of death is rather obvious, but perhaps it's a more social issue that Janelle could explain. Because people are elderly in my work, it seems that their cause of death is normally more apparent. So the process is very legal in Quebec. I'm not sure who this person is located, where this person rather is located in Canada, the person who asked the questions, but I'm not aware of this problematic in Quebec.
Okay, and Janelle, do you have anything further to comment or add?
I think it's a really interesting question or a fact, I guess. I'm sorry, I don't really have any light to shed on that.
All right. Well, if anyone else does, feel free to add that to the chat, or this individual did provide their email address. So if anyone had some specific information, we could perhaps send that information on to them. All right, thank you. So going to another question then, perhaps, I think, again, this is probably something for either of you to answer. So if either of you would like to step forward. They're asking or stating that the ethics of risk is a relatively new concept. Are there academics or working groups focusing on this in Canada in the context of neurocognitive or neurodegenerative illness? So clinicians and decision makers tend to have a lower threshold of acceptable risk for older adults at the risk of impeding a person's autonomy and right to make what we believe are quote unquote poor decisions. So do either of you have any comments or knowledge of, again, the question's more around whether there's particular academics or working groups in Canada looking at the notion of ethics of risk, balancing respect for autonomy and harm.
I will have to say I'm still a relatively recent transplant to Canada, and I feel like there's a lot I don't know about what's going on, but I know that in the US, Jason Karlowish and others have been looking at the questions of consent and capacity and the right to make bad decisions. And I do know that also in looking at these materials about older adults who are kinless when they develop dementia, often the health system was aware that there was a problem and did bring in social workers, and they often called for a geriatric consult, and you get people together to investigate the situation, and there's a conclusion that the situation is not okay, it's not tenable, it's not safe, and the person is unwilling to do anything to change it. So I think it's actually a really common and interesting problem. And maybe, Felix, if you know people who are working on that within ethics.
Pour le Québec, c'est vrai aussi que c'est un concept assez nouveau.
In Quebec, it's a new concept, especially when we talk about dignity of risk. In Canada, I'm not sure, but I know that in Quebec, there are various committees where I'm involved, especially in geriatrics, but balancing safety and autonomy, obviously in geriatrics, when I talked about major neurocognitive problems like dementia, these evolve, and the more person is severely diseased, the more we'll protect them. Generally, if they are more competent, then we leave them alone. There's also issues with, for instance, alcohol consumption. Some are more confused when they consume alcohol at home. They're sent to hospital, they don't consume alcohol, they're more lucid, but when they go back home, they begin consuming again. So at the end of the day, are they able to manage their alcohol consumption? Is that a safety issue? We have that responsibility. Maybe I should also mention that there's also the most responsible attending physician. So yes, we need to care in a way that may seem paternalistic, but there's an important problem here. If there's a significant loss of self-reliance, if this person is reliant on others to make decisions or make good decisions, then other principles become involved, and it's no longer autonomy that is at the forefront, but more safety. Should we compel caregivers to do something because the person who has advanced cognitive disorders does not realize that they have a disorder and is losing their self-reliance and forcing others to look after them? So there's an intergenerational issue at play as well. Should we let children feel responsible for poor decision making by their parents? So as professionals in geriatrics, even more than psychiatry, we try and focus more on care and safety, because the person is less and less able to make decisions for themselves, especially when they're fluctuating. Some days they can, some days they can't. So in a way, I think we can be justified in saying that, given that the disease is so advanced that they require protection.
Great, thank you. And I just want to also add, I too don't know any specific scholars in this particular field looking at the questions, but in terms of working groups, I could just speak to my place of work at the Vancouver Coastal Health Authority in BC. This is it is actually the top question that we get consulted about as ethicists. Our ethics team and our ethics committee around is balancing, the right to choose to live at risk, and what is the nature of risk involved. And so we developed, as an interdisciplinary team, alongside legal and risk, but also professional practice and other clinicians, a tool. It was more of a guiding decision support tool for clinicians to work through in these very complex situations, more in community and long-term care, balancing, what is the process involved to really weigh up the notion of risk and the dignity of risk, which Felix also spoke to, which really requires collaborating with the person in care or their supportive decision makers, whomever is involved in their care network, in determining not only what is the nature of risk, so understanding who's at risk, how severe and probable is the risk, activity or inactivity in some cases, but also the benefits. Again, speaking to that dignity piece, the benefits of engaging and helping to weigh up, again, depending on who's at risk, the level of cognitive impairment or other encumbering factors shaping the decision-making process. So again, it's not a scholarly piece of work, but it is interprofessional teams, and a lot of our education that we try to provide in our ethics service is around weighing those very complicated decision points up around balancing harm, both to self, but also to others, and what's our duty to intervene, and what does that look like, given that dignity and autonomy is also equally as important, whether someone is incapable or not. There is still dignity and risk. So just some thoughts there, and I'm happy that's a public document if anyone wanted to see how we put that together. Going now to the next question, we have someone asking that sounds like from Switzerland. They're interested in whether advanced directives and advanced care planning, more generally or broadly, whether the numbers of uptake raised during the pandemic in Canada. Was there also some promotion for AD and ACP? So AD being advanced directives and advanced care planning. Dr. Janelle Taylor, maybe let's start with you, given I know you had some background in advanced care planning. I know you're saying you're a recent transplant, so perhaps you're not as well tuned to the recent publications or research in Canada on the subject at this time. But if you are aware of, again, what the uptake around advanced care planning in Canada, specifically around the last few years with the pandemic, if our numbers have increased?
I actually don't know the answer
No.
to that. I mean, I think that one problem with the pandemic was that there wasn't a lot of advance notice to be doing that kind of advanced care planning. So I'm not sure.
Okay. And Dr. Pageau, how about from your understanding or experience, did you see, even if you don't have like the stats on what our numbers increased or whatnot overall, did you see that in at least your clinical practice?
C'est assez nouveau, c'est des chiffres demeurent assez bas. Nous, on
It's
doit
quite recent, and the figures continue to be low. When somebody has a severe or advanced cognitive disorder, we tend to look for advanced care planning and directives, and we rarely find them. It's a complex process. It's not well known, so there's not much uptake for it. It may have increased a little bit, but overall, there's not much uptake.
Thanks. And yeah, and I can't speak to what the stats in terms of evidence base in terms of uptake, but I certainly know, at least in the BC context, that was a huge emphasis in terms of around at least education and a lot of promotion at the clinician level to engage in advanced care planning in relation to COVID, in particular in long-term care sites and other sites, to ensure that people's wishes are up to date and well understood in light of the risk, and I would imagine in the older adult population directed specifically, given the risk to that population. Janelle, yes, over to you.
I was just going to say, this doesn't answer the question about what effect the pandemic has had. I don't know, but I was going to say that anything that increases fragmentation in a health system also undermines efforts to implement advanced care planning, because someone will fill out a form, but then in the moment, where is it? Did they actually do it? Who knows what's on it? The one example that I'm aware of a relatively successful effort to address this is the state of Oregon has a pulsed registry. So they ask people to fill out physician-ordered orders for life-sustaining treatment, and then they have actually a registry where everyone puts it in that registry, and then physicians, whatever circumstances they might encounter someone where this becomes a question, they know where to go to look for it. But that's like one state, and I don't know whether similar efforts have been implemented or systems set up in other places. So I think it's really a patchwork, as far as I know.
Yeah, I think the same is true for Canada. Felix.
Oui, je voulais juste compléter parce que
I just wanted to add, because in Quebec, we do have advanced directives, but we also have alternative levels of care that will become care goals. So do you want to be resuscitated? Do you want critical care, survival care? Do you want comfort care? In Quebec, during the pandemic, people were really made aware of the intensive use of critical care. So the idea of having a conversation with a level of care that you should have, or what is the goal of the care, that's something that we're trying to raise awareness about. It's really a conversation between the physician and the patient, and that's not a form, and it's not there's no repository for it in Quebec, but it's more about level of care, how much care. All geriatric patients almost have the equivalent of the do not resuscitate the DNR. We don't have an equivalent in Quebec. It's rather what level of care do you want to get critical care or not? So it's not quite the same, but it's similar. But it's the kind of conversation we're having in Quebec, and it did increase during the pandemic.
Okay, thank you. And I'm seeing a number of comments asking about sharing the link to the VCH decision-making tool, and I'm happy to do that. The link, though, is on a private kind of server, so I don't have a link that most of you would be able to access, but I could share a PDF version. So I'm not sure, Corey, is that something I could email out afterwards or something as a resource? Okay, I will definitely do that. And I want to turn back. We only have a few more minutes together. Someone posed earlier, and I want to circle back to some of the things coming out of Dr. Pageau's presentation, because I was interested in it. It sounded like other people were also interested in hearing from you, Janelle, about your reflections about care robots, or the notion of a social robot. So I wonder if this, maybe in a minute or two, if Janelle, you wanted maybe a bit of a refresher from Felix around, you know, the or for all of us, Pageau and other social robots, and what that kind of looks like in terms of addressing the ADLs, or activities in daily living and dignity and care at home. But I think folks were really interested in your thoughts, Janelle, given your research and your looking at that more relational notion of personhood, and whether this care robot idea might be something to help balance, or what might be some ethical considerations there from your lens.
Yeah, I don't know. I mean, I think that we talked a little bit about this when a small group of us, including Felix and I, had a little pre-conversation. I think about this in terms of thinking about the questions that I came to while researching this other technology, right, which was these ultrasound imaging, and sort of there are purposes that the technology is designed to pursue, and then there are the ways that it gets used and the meanings that get attached to it, and the consequences, which are often quite different from what had been planned or anticipated. And you know, I think that whatever the problems that you know, a care robot or Pageau the seal or some of these things is meant to solve, first of all, I would want to know, like, empirically, does it work, right? Does it seem to actually meet those needs? Does it seem to solve those problems? I have heard people talk about going to care homes where they find the Pageau stuck off in a corner in a closet, and it doesn't get used. And so, you know, I don't know, is it actually being used or not? And if it is being used, then we can ask, you know, is there something inherently problematic about the fact that it's not a person? Maybe not. We can debate that. But there's that first kind of empirical level of, like, are people even using it? I think also there are just questions backing up a step. There are questions we should be asking about priorities and costs and emphasis. Like, you know, if it costs, say, $6,000 to buy a care robot, I'm making that number up, I have no idea how much it costs, but if it costs X amount of money to buy a care robot, is that the best use of the funding? I mean, you know, a budget is always nothing more and nothing less than a statement of priorities. So what are the priorities that we're acting on when we choose to invest in technology, as opposed to choosing to invest in people, for example? And I understand that it's complicated, and there may be a shortage of people. That too may be something where we have to back up and say, well, what are the structural features that we could try to think about as contributing factors to why we're not able to get people to enter into and stay in this line of work, if that's actually the problem that the robots are trying to solve.
Thank you. And Felix, do you have anything to add or comment on further?
Oui, rapidement, ben, en fait, il y a des études, même des
Yes,
méta-analyses.
there have been studies and meta-analyses on robots that look like animals that would be as efficient or effective as zootherapy, but you don't have to feed or change the litter of the pet of the animal. But those studies were funded by industry, and in the meta-analysis, as Janelle said, the question, the issue we're trying to solve is important. What are we trying to solve with these robots? And indeed, working conditions of people who work in geriatric care are not necessarily excellent. So if a patient becomes attached to Matilda or Paro rather than have an effective relationship with a caregiver, the robots become receive the affection of patients. So I think that this is the issue with robots. We're replacing affection that is given to a robot that doesn't need it, rather than a human being that, like the caregiver, who needs it in order to provide careful care or a good care and improve relationship with the patient.
Thank you kindly for that. So we just have a couple minutes. I think enough time maybe for one last comment, but I just want to check in too. I haven't heard anything about, or I don't want to make sure I missed it. No hand raised at this stage. Okay, great. We do have one last Q&A question that I think may be best addressed by Felix, just because it is somewhat of a clinical determination. It's also a legal one though, depending on which legislation we're looking at. But the question is, what are current definitions of a vulnerable adult in considering capacity for decision making? And then I'll turn it over to Janelle if you have anything for further thoughts. But or Victoria would like to perhaps answer this question. If I'm seeing a comment here. I'm not. Is that right, Victoria? Were you wanting to jump in?
Nope.
Oh, okay. I'm sorry. I don't know why that is on there. Sorry, it's over to you then, Dr. Felix Pageau, if you want to address that question.
En fait, c'est très intéressant parce qu'il y a un débat.
It's very interesting because there is a debate even in geriatrics researcher, and this is a topic of further work with a colleague, Ms. Giroux. Is the person vulnerable or in vulnerable circumstances or situation, or is it because of the environment that she is in a situation where that they could injure themselves, or what is important is the state of frailty, and that's a medical concept. And but vulnerability, I think a person is vulnerable if they are in an environment that's not a caring environment. If it's where the risk of being wounded or injured is higher. We were talking of the consumption culture where people are not as efficient for society, are considered to be second-class citizens, and they're put in a vulnerability situation. I'm not really answering the question, but we're going to work on it. This is going to be part of further research.
Yeah, and I wonder if that relates more to like the notion of like structural vulnerability versus being a vulnerable adult under, say, like the legislation wherein we oath in terms of the decision-making authority and whatnot. But I'm going to stop there and just make sure that Janelle, if you had anything further to add on that question or comment, no, because we are at time and I don't see any other questions. So I think we covered everything, and thank you everyone for joining and having the time with us today, and in particular to Dr. Janelle Taylor and Dr. Felix Pageau. it was a wonderful conversation, and I feel very honored to have shared in today's talk with you all. And so I'll pass it over to you, Corey, to provide the final remarks.
Thank you. That's great. I mean, talk about timekeeping. That was done on point. Just very quickly, I think there was a lot of wisdom in having paired a medical anthropologist with a clinician for these types of questions, right? I mean, I would love to see continued conversation between anthropologists, theologians, sociologists, especially in, you know, kind of linked to clinicians who are on the ground, even just about the terms that we use, right? And I'm thinking, for instance, about whenever I've heard Felix speak on many occasions on fragility as a diagnosis, right, which he did today. And that's always striking, I think, to those of us in the social sciences and the humanities. Just the fact that that itself is a medical diagnosis, the word fragility with a certain kind of set criteria. I think also about this last conversation about the word or the adjective social in social robots, right? When Felix, and I know Felix has a really interesting critique about this whole model, but the idea, and he mentioned this in his talk as well, that social robots, you know, we don't want to be thinking about them as persons, but as instruments and as means. And yet we still refer to them as social. And so that whole question, right, about what does this really mean? And this is where I think there's a deep need for interdisciplinary discussion. And so I'm grateful for today's conversation. My abiding thanks to Catherine, Andrew, Victoria, Amanda, and our translators, Janelle and Karine, for your commitment, I think, to this fantastic conversation series. My gratitude to Kim for such skilled and refined moderating, to Felix and to Janelle for two really wonderful presentations. Thank you. Thank you. And to our audience, of course, for your participation and for your support throughout this entire series and for the other activities that we invest in here at the CBS. We look forward to seeing you all at the next Conversation Series event on November 7th. And with that, I bid you all a very good day. Thanks, everybody.
Au revoir. Merci.